Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about thalassemia, and thalassemia specifically during pregnancy. So what we wanted to discuss today, the definition, epidemiology, pathophysiology, clinical features, pre-pregnancy evaluation, prenatal diagnosis, and the pre-implantation diagnosis, antepartum management, intrapartum management, postpartum management. Let us start with the definition. Thalassemia is a quantitative disorder of globin chain production that either affect alpha or beta globin chain. All of us know that hemoglobin is formed of 2 alpha and 2 beta globin chain in adult hemoglobin, what's called hemoglobin A. Okay, so we have 2 alpha and 2 beta, okay, in adult hemoglobin. So quantitative disorder of globin chain production that either affect alpha or beta globin chain is called thalassemia. This thalassemia is inherited as autosomal recessive hematologic disorder, which causes hemolytic anemia because of decreased or absent senses of globin chain, imbalances of globin chain cause hemolysis and impair erythropoiesis. What about the epidemiology? Approximately 5% of the world's population has globin variant, but only 1.7% has alpha or beta thalassemia trait. Thalassemia affect men and women equally and occur in approximately 4.4 of every 10,000 live births. Alpha thalassemia occur most often in persons of African, Southeast Asian descent, while beta thalassemia is the most common in persons of Mediterranean, also African and Southeast Asian descent. What about the pathophysiology? Please look to this picture, the two pictures about the chains of globulin. Hemoglobin consists of an iron-containing heme and ring. Iron-containing heme ring and the 4 globin chains. What about these 4 globin chains? 2 alpha and 2 non-alpha. The other 2 may be beta to form adult hemoglobin, what is called hemoglobin A. Or the other 2 chains may be gamma globulin, which form the fetal hemoglobin, hemoglobin F. So hemoglobin F is formed of 2 alpha and 2 gamma. If 2 alpha and 2 delta chains will form hemoglobin A2. Okay? But the normal adult hemoglobin, what's called hemoglobin A, has 2 alpha and 2 beta chains. Okay? Clear? What happened at birth? At birth, hemoglobin F accounts for 80% of hemoglobin, and the hemoglobin A accounts for the remaining 20%. The transition from gamma globin synthesis, which is a part of hemoglobin F, to beta globin synthesis, which form hemoglobin A, begins before birth. By the 6 months of age after delivery, the healthy infant will have transitioned to mostly hemoglobin A, and the small amount of hemoglobin A2 and the negligible amount of hemoglobin F. So the main and the major category is hemoglobin A, which is formed of 2 alpha and 2 beta chains. Small amount of hemoglobin A2, which is formed of 2 alpha and 2 delta. And the negligible amount of hemoglobin F, which is a fetal hemoglobin, which is formed of 2 alpha and 2 gamma chains. Okay? Okay. This is after 6 months of delivery. So what is the chromosomes responsible for that and they carry the genes for alpha and beta and the others? Chromosome 16 for alpha gene cluster, while chromosome 11 for beta gene cluster. Okay? Okay. This picture show you the genes in the chromosome 16 and 11. 16 responsible for alpha clusters, 11 responsible for beta clusters. Alpha thalassemia is the result of deficient or absent synthesis of alpha globin chains, leading to excess beta globin chains. Alpha globin chain production is controlled by 2 genes on each chromosome. Deficient production is usually caused by deletion of one or more of these genes. So, alpha thalassemia affected by 4 genes, 2 genes in each chromosome, while beta thalassemia affected by 2 genes, 1 gene in each chromosome. Okay? This table show you the alpha thalassemia categories. If single gene or 2 gene deleted or 3 gene deleted or 4 gene deleted, what will happen? If single gene deleted in alpha thalassemia, there will be alpha thalassemia silent carrier status, which is asymptomatic with normal hematologic finding. But if 2 gene deleted, alpha thalassemia is called alpha thalassemia trait or minor, with microcytosis and usually no anemia. Then the more hazardous one is the 3 gene deletion. The 3 gene deletion results in significant production of hemoglobin H, which has 4 beta chains. Alpha thalassemia intermediate or hemoglobin H disease causes microcytic anemia, hemolysis, and splenomegaly. Let us go to the severest form, which is the 4 gene deletion. The 4 gene deletion results in significant production of hemoglobin parts, which has 4 gamma chains. This alpha thalassemia measured with hemoglobin parts usually results in fetal hydrops fetalis, so it interferes with life. What about beta thalassemia? Beta thalassemia is the result of deficient or absence synthesis of beta globin chains, leading to excess alpha chains. Beta globin synthesis is controlled by, as I mentioned before, 1 gene on each chromosome. Beta thalassemia occurs from any of more than 200 point mutation, and deletion of the 2 genes is rare. Beta globin chain production can range from near normal to completely absent, leading to varying degrees of excess alpha globin to beta globin chain production. The 1 gene defect, which is called the beta thalassemia trait or minor, is asymptomatic and result in microcytosis and mild anemia. If the census from both genes is severely reduced or absent, the person has beta thalassemia major, also known as Colles anemia. Persons with beta thalassemia major are almost never symptomatic at birth. Why? Because the presence of hemoglobin F. As all of us know, after delivery there is still enough amount of hemoglobin F. But symptoms begin to develop by 6 months of age when hemoglobin F becomes negligible. If the census of beta change is less severely reduced, the person has delta thalassemia intermediate. These persons experience symptoms that are less severe and don't require lifelong transfusion to survive past 20 years of age. Look to this table, please, about beta thalassemia categories. Notice the difference. We know there is 2 genes responsible for beta thalassemia. This is the normal one, the upper one, then the beta thalassemia trait, then beta thalassemia intermediate, more severe, then the most severe one, beta thalassemia major or Colles anemia. What are the characters of the 3 categories? In beta thalassemia trait, thalassemia minor, there is maybe no symptoms or mild microcytic hypochromic anemia. While in beta thalassemia intermediate, there is variable severity, mild to moderate anemia, possible extramedullary hematopoiesis, and iron overload, which is dangerous. Beta thalassemia major, characterized by severe anemia, transfusion dependence, extramedullary hematopoiesis, and iron overload, which constitutes rest in many organs like heart, liver, and so on. Look to this picture. This is the transfer of genes from parents to children. The possibility if both are carrier of occurrence of thalassemia major is 25%, as you see from the picture. If one of the parent is carrier and the other one is normal, the possibility of carrier will be 50% and no possibility of thalassemia major. Let us go to the clinical features of the thalassemia. Patient with beta thalassemia intermediate present after the first 2 years of life with moderate anemia and don't require regular transfusion. The main clinical feature in these patients are hypertrophy of erythroid marrow with medullary and extramedullary hematopoiesis and its complications. What are the complications? Osteoporosis, masses of erythropoietic tissue that primarily affect the spleen, liver, lymph nodes, chest, and spine, and the bone deformities and the typical facial changes. Also, there may be gallstones, painful leg ulcers, and an increased predisposition to thrombosis. Individuals with beta thalassemia major usually present within the first 2 years of life with severe anemia. Severe anemia because this is beta thalassemia major one, requiring regular red blood cell transfusion for survival. And the prognosis of this thalassemia major was very grim before treatment became available. But if no treatment, the natural history was for death by the age of 5 years old from infection and cachexia. The first advance in treatment was the initiation of episodic blood transfusion when the patient was going through a particularly bad time. So the first advance, these children in the past used to die at the age of 5 from cachexia and infection, as I said, those with beta thalassemia major. But with the development of availability of blood transfusion, this is give a chance for survival for these patients. Okay? And was prolonged to the second decade of life. But it soon became evident that the treatment that saved the lives of children caused death from cardiac disease in adolescent age. The prognosis for individuals with beta thalassemia major dramatically improved with the advent of desferroxamine. Desferroxamine, when developed, which is a chelating drug, chelating agent, removing the excess iron load in circulation which deposit in organs. This is another advantage of the new lines of treatment in the previous years, and they save life. So we have two improvements: blood transfusion and the availability of chelating agent drugs, either IV drugs or oral drugs. However, many transfusion-dependent patients continue to develop progressive accumulation of iron, and which can lead to tissue damage and eventually death, particularly from the cardiac disease. In recent years, transfusional and therapeutic advances, including the availability of oral iron chelators and the new non-invasive methods for early detection and treatment of iron overload, have significantly improved the life expectancy and the quality of patients with thalassemia, with a consequent increase in their reproductive potential and the desire to have children. So, with the development of the blood transfusion and iron chelating agents, drugs like desferroxamine, the patient has a chance to have a healthy life, and reproductive potential becomes good, and their need for having children occur. Symptoms and signs of thalassemia may include feeling tired, weakness, breathless, pale or yellow skin, deformed bone in the face as in this picture, slow growth, dark urine, complication of blood transfusion and the drugs given. Most persons with thalassemia trait are found incidentally when their complete blood count show a mild microcytic anemia. Microcytic anemia can be caused by iron deficiency or thalassemia or lead poisoning or sideroblastic anemia or anemia of chronic disease. Then how can you differentiate between those? There is differential diagnosis for microcytic anemia. The mean corpuscular volume, red blood cell distribution width, and the patient's history can exclude some of these etiologies. Supplemental tests include serum ferritin, the peripheral smear, hemoglobin electrophoresis, serum lead level, and rarely bone marrow aspirate. Serum ferritin is the best test to screen for iron deficiency anemia and to exclude it in absence of inflammation. A normal ferritin level generally exclude iron deficiency. Serum iron, total iron binding capacity, and transferrin saturation are rarely needed. Sideroblastic anemia can be excluded with an examination of the peripheral smear or the bone marrow aspirate. A normal serum lead level exclude lead poisoning. Anemia of chronic disease is most often a normocytic normochromic mild anemia, so it is not microcytic. If thalassemia is still suspected, a hemoglobin electrophoresis may help diagnoses this condition. And in this picture, you can define the thalassemia here in hemoglobin electrophoresis with beta thalassemia trait. Usually has reduced or absent hemoglobin A, elevated levels of hemoglobin A2, and the increased hemoglobin F. However, a normal concentration of hemoglobin A2 doesn't rule out beta thalassemia trait, especially if there was coexistent iron deficiency, which can lower hemoglobin A2 levels into the normal range. The hemoglobin electrophoresis is usually normal in adults with alpha thalassemia trait. What is very important as regard our topic today, which is thalassemia, is the pre-pregnancy evaluation in women with thalassemia. There is certain points should be covered as a pre-pregnancy evaluation. For partner, beta thalassemia status should be known, blood typing, spermiogram. For fertility, we should know the menstrual history. We do hormonal assay, including anti-Mullerian hormone, to know the ovarian reserve. Standard pelvic examination, pelvic ultrasonography, hysterosalpingography. This is as regard the fertility factor. For iron overload, do serum ferritin, heart MRI, liver MRI to detect any iron deposited and hemosiderosis. Heart function, cardiologic evaluation, ECG, 24-hour Holter monitor, do echocardiogram. For liver function, do liver biochemical tests, liver enzymes and so on, liver and gallbladder ultrasound, and do fibroscan. For endocrine function, do thyroid function test, glucose metabolism test, vitamin D level, and DEXA for osteoporosis. For infection, do TORCH, Toxoplasma, Rubella, cytomegalovirus, herpes simplex, and viral infection like HIV, hepatitis B and C markers, and also syphilis. For thrombophilia, take personal and family history of thrombosis, inherited thrombophilia panel, acquired thrombophilia panel, and do the investigation needed in high-risk cases. Others like medication review, extended red cell phenotyping, and screen for red cell antibodies. This is a pre-pregnancy evaluation in women with thalassemia. What about the preconception counseling about the risk? You should tell the woman about the risks as regard the maternal and the fetal risks. What is the maternal risk? The most important is cardiomyopathy. Due to iron overload and increased also fetal risk, which specifically the fetal growth restriction and also miscarriage. In addition, with around 9 months, the month of pregnancy, of little or no chelation, women with thalassemia may develop new endocrinopathies. Because during pregnancy, you are trying to avoid chelating agent during pregnancy due to its hazards and maybe side effects and the fetal teratogenic effects. So, avoiding these chelating agents may predispose to others. Okay? And the development of endocrinopathies like diabetes mellitus, hypothyroidism, hypoparathyroidism, due to increased iron burden because you are not using chelating agent during pregnancy. So you should counsel the patient about this, and you should do correction for any iron load before planning for pregnancy by using chelating agents. So this is very important to be done before planning to be pregnant. What did the medication review include? before pregnancy is actively contemplated or ovulation induced, potentially teratogenic medication needs to be reviewed. Like what? What is the teratogenic drugs? You should ask the patient to avoid if she is planning for pregnancy. Hypoglycemic agents, biphosphonates, which is used in osteoporosis, ACE inhibitors, used in hypertension, women on oral chelators like Defracirox, what's called DFX, are recommended to switch to deferoxamine, DFO. Defracirox is used orally, as in this picture. This is Defracirox, and the abbreviation is DFX. It is worldwide abbreviation, DFX, Defracirox. This is taken orally, while deferoxamine, with abbreviation DFO, as in this picture, is used by injection. So it is advised to shift from this oral one to the deferoxamine, which is given by injection. Okay? Okay. Before starting induction of ovulation, we are talking before pregnancy. Medication that should be discontinued at least 6 months period to fertility treatment include interferon, ribavirin, and hydroxyurea, because it has a prolonged effect. Okay, so you should stop before planning for pregnancy by 6 months. Hypothyroid patients should be corrected with levothyroxine to reach the euthyroid state. What about prenatal diagnosis? Couples at risk of having children with beta thalassemia should be informed that the risk is 25% of having thalassemia major fetus. Okay? So, how can I do prenatal diagnosis? Diagnosis can be made either in the first trimester at the age of 11th week by chorionic villus sampling and genetic study and the chromosomal study, or after 16 weeks by amniocentesis, for taking fetal cells and study the chromosome, do karyotyping and the genetic study, and diagnosing if the patient has, if the baby has thalassemia or not. Is there any risk of miscarriage in these procedures, the chronic chorionic villus sampling and amniocentesis? Very rare complication as a miscarriage, less than 1% in post procedure. What is also important is the pre-implantation genetic diagnosis, which is done before IVF, okay, or during IVF. You are using this to avoid occurrence of pregnancy and doing chorionic villus sampling and discovering thalassemia major, then termination of pregnancy or induction of abortion. So from the start, you can prevent pregnancy if you did pre-implantation genetic diagnosis by taking nuclei from oocyte, polar body, or embryos, blastomeres, to test for mutation in the target gene or aneuploidy before transfer. Okay, if you found the gene is present, measured, thalassemia measured, so you are not going to transfer the embryo. What about antepartum management in thalassemia? Pregnant women must be reviewed monthly till reaching 28th gestational week and every 2 weeks thereafter. Preterm birth related to poor maternal condition, fetal distress, and placental ischemic disease can complicate pregnancy. What are the other complications expected to happen? Gestational hypertension, gestational diabetes, placental abruption, urinary tract infection, renal and gallbladder stones, and cardiomyopathy. That's why close maternal observation and regular follow-up is very important in thalassemia during pregnancy. Women should be screened for gestational diabetes at 16 weeks and 28 gestational age. Furthermore, heterozygous thalassemia in ethnic group with high diabetes mellitus incidence should be screened for gestational diabetes more frequently. Splenomegaly can interfere with enlargement of the uterus and can be complicated by hypersplenism, necessitating splenectomy during gestation or after delivery. What about fetal monitoring? We can do it by ultrasound, starting with 7th and the 8th weeks of gestation. By doing ultrasound, for women have a high risk of miscarriage and multiple gestation because they are carrying thalassemia or having thalassemia. In addition, again, I'll ask the patient to come to see her by ultrasound at the age of 11 to 14 weeks gestational age, and during second trimester between 18 to 21, scan for biometry scan, for fetal growth, for any anomalies, for amniotic fluid, for any evidence of fetal growth restriction, because it is a possibility to occur during pregnancy in thalassemia. The percentage of babies with IUGR varies among different studies as spontaneous conception, IVF cases, and the singleton and the multiple pregnancy are encountered. Miscarriage occur mostly in cases of thalassemia homozygous fetus or those with severe IUGR. The reported frequency varies from 9% to 33%. What about maternal transfusion, blood transfusion during a pregnancy? All of us know that anemia in women with thalassemia deteriorate during the pregnancy. However, some mild anemia may be passed undiagnosed without screening, and the pregnancy continue normally. Thalassemia per se, in combination with gestational anemia, secondary to increased fluid compartment of the body, account partly for different complications of thalassemic pregnancy, like fetal intrauterine growth restriction and the preterm labor. Most centers transfuse pregnant women, aiming for what? Aiming to reach the hemoglobin above 10 gram per deciliter. Why above 10? To ensure appropriate fetal growth, okay, and to minimize the occurrence of intrauterine growth restriction. Despite following this approach, IUGR may be present, suggesting that the role of other fetal-placental and maternal factors, while transfusion acquired red cell antibody should be checked prior to pregnancy. So, fetal growth restriction may be related to anemia, but if I corrected the anemia above 10 gram per deciliter, still possibility of occurrence of fetal growth restriction because there is another problem as regard the fetal placental factors and the maternal factors. Women never or minimally transfused. When blood transfusion is necessary, extended genotype and the antibody screening should be performed and the fully phenotype matched blood given. Why? To avoid alloantibodies which can stimulate anemic the hemolytic anemia aggravation. The decision to initiate transfusion regimen is based on the presence of worsening maternal anemia or evidence of IGR. And in this case, regular transfusion should be considered. And of course, blood transfusion carry risks of transmission of infection, viral infection, HIV, and so on, so HCV, hepatitis B virus, and so on, and the other complication of blood transfusion, including also iron accumulation in circulation and the deposit in organs causing damage. So it is important to know about this complication. In general, non-transfused women with hemoglobin above or equal to 8 gram deciliter, some at 36 weeks gestational age, some advise not to initiate blood transfusion, but give erythropoietin hormone injection will elevate the hemoglobin without any need for blood transfusion. This is for those women who never got transfused before and the hemoglobin above 8 gram. You can raise this hemoglobin and improve it by erythropoietin hormone if the gestational age is 36 weeks or more. Okay? Chelating drugs during pregnancy. Throughout pregnancy, acceptable levels of maternal hemoglobin should be maintained to minimize hypoxia, but intensive transfusion treatment can aggravate hemosiderosis. And this is one of the complications of blood transfusion. In patients with pre-existing iron overload status, elevating oxidative stress and inducing organ failure, whereas women identified with cardiac hemosiderosis or borderline left ventricular function may bear heart complication. Therefore, the role of chelation during pregnancy should be clarified. Okay, what about chelating agent? Can I use it during pregnancy or not? What is the role of chelation? Chelation therapy will reduce iron overload and help free radical scavenging, reducing the inflammatory process. But deferoxamine, what's called DFO, can cause fetotoxicity. Still not proved in human, but proved in animal studies. Okay? So it is contraindicated during the pregnancy, and if it is given because the benefit of giving the drug overweight the risks. Okay, this is a picture of the furoxamine injection. According to expert, DFO should be avoided during the first trimester, but subcutaneous administration may be considered in second and third trimester for patients with a strong indication for treatment. As to oral chelators, according to experimental models, placental transfer of defracirox, DFX, as I said before, is minimal in rats, but fetal outcome data in humans are limited to spontaneous pregnancy case report, and based on the product label, DFX use is contraindicated in pregnant women. So I shouldn't use the oral chelating agent defracirox. During pregnancy, chelation should be restricted for cases where the potential benefit outweighs the potential fetal risk. If a woman describes cardiac symptoms during pregnancy, she should immediately be assessed by a cardiologist with expertise in thalassemia in order to balance the risks and decide on the need of chelation for chelation treatment. What about thromboembolism during pregnancy in thalassemia? All of us know that pregnancy itself is a hypercoagulable state, and there is a risk of thromboembolism due to increased coagulation factor 2, 7, 8, and 10, okay, and fibrin generation, and increased contrary to fibrinolytic activity, and decrease free protein S, and decrease fibrinolytic activity. Okay, so there is increase in coagulation factor and fibrin and fibrinogen, and the decrease fibrinolytic activity and protein S. So there is tendency for thrombosis and thromboembolism during a pregnancy, and the pregnancy is considered risk factors for this. Add for this the venous stasis, the stasis of blood, mechanical stasis during a pregnancy. Okay, the patient may have rest more time, lie in bed for longer time maybe. So there is venous stasis, mechanical by the enlarging uterus. So we have hypercoagulability and the venous stasis, and all of these are risk factor for thrombosis and thromboembolism. Add for this, the patient may carry other risk factors for thromboembolism, like inherited thrombophilia or antiphospholipid syndrome, and may have a history of previous deep venous thrombosis. So during a pregnancy, there is risk of thrombosis. What about if the patient has a thalassemia also? The risk is much higher because thalassemia increases the risk of thromboembolism. So there is increase in the risk of thromboembolism due to thalassemia, with a risk as high as 29%, especially in splenectomized and non-transfused patients. And this is a very important because thrombosis and thromboembolism is life-threatening. So, inherited red cell defects that activate endothelial cells, creating a procoagulant state, along with platelet abnormalities, deficiency of coagulation inhibitors, cardiac and liver dysfunction, and hormonal deficiency, seems to compromise the pathophysiology of thromboembolism. Therefore, frequently transfused patients have lower rates of thromboembolism compared to those who are not transfused. Thromboprophylaxis is important in patients with thalassemia during pregnancy. In cases of non-transfused patient and patient with splenectomy or history of recurrent abortions. According to recent data, low-dose aspirin frequently administered to splenectomized beta thalassemia patients seems to be effective in preventing preeclampsia, preterm birth, and the IUGR in high-risk pregnancies. Okay, and this is already known, well-known information that low-dose aspirin rule in prevention of preeclampsia, preterm birth, and the IUGR in high-risk pregnancy. What about in splenectomized women with platelet count more than 600,000 per microliter? Should have aspirin 75 milligram per day plus low molecular weight heparin. This is very important to be known. So we said pregnancy itself is in a hypercoagulable state, and the patient has a risk of DVT and thromboembolism. Thalassemia aggravate the risk much higher, up to reaching maybe 29%. And all of us know that thromboembolism is life-threatening, so I should give the patient low molecular weight heparin, specifically for patients who have splenectomy and who have platelet count 600,000 per microliter or more. plus I will give aspirin in a dose of 75 or 81 milligram per day oral to protect from preeclampsia, preterm birth, and IUGR. What is very important also during pregnancy and before pregnancy, medication modification. Medication modification, the patient should be asked to modify their lifestyle and diet, avoid smoking and alcohol, and take supplements like folic acid, calcium, and vitamin D before pregnancy and during pregnancy. Okay? Also postpartum during breastfeeding. So adequate calcium and vitamin D intake is important. Can I give biphosphonate, which is used for treatment of osteoporosis during pregnancy? No. Biphosphonate is contraindicated during pregnancy. Okay? But I'll give calcium, vitamin D, and folic acid. You should know that I need the larger dose of folic acid supplementation, which is 5 milligram per day, to protect from fetal neural tube defect, and also is important to prevent superimposed megaloblastic anemia. What about intrapartum management? Intrapartum management, including the time and the mode of delivery. What is the time and what is the mode of delivery? Really, it should be individualized in cases with thalassemia. Uncomplicated disease course shouldn't be considered a proper indication for cesarean section. So, you should give the patient the chance for vaginal delivery. But why cesarean section is done frequently in thalassemia? Mostly due to cephalopelvic disproportion, due to short maternal stature and skeletal deformities, combined with normal fetal growth. So, the cause of cesarean section here is related to cephalopelvic disproportion. What is the anesthesia used in case of cesarean section? Epidural anesthesia is preferred compared to general anesthesia. Why? Because maxillofacial deformity in thalassemia patient may cause difficulty in intubation. Okay? Also, something important to know is to correct osteoporosis where required. Preconception is very important. Why? Because spinal abnormalities associated with thalassemia are relevant to regional blockade. So you may fail to do spinal anesthesia or epidural anesthesia because there is a spinal deformity because of osteoporosis. So from the start, before planning for pregnancy, you should correct osteoporosis. You should avoid spine deformity because all of this may cause obstacle also when you are doing regional anesthesia or epidural anesthesia. This is important to be noted. If vaginal delivery is decided, active management of third stage of labor is recommended as this intervention decreases the blood loss. This is very important to be known. Fetal hypoxia is common during labor and the continuous electronic fetal monitoring is required. Transfusion-dependent women that are not chelated will have high concentration of non-transferrin bound iron in the serum. A toxic iron form which can cause cardiac dysrhythmia in combination with labor stress. Therefore, intravenous deferoxamine 2 gram over 24 hours is recommended for the duration of labor. to avoid this cardiac dysrhythmia. What about postpartum management? There is a high risk of venous thromboembolism for women with thalassemia. Okay, so I should continue low molecular weight heparin for 7 days if vaginal delivery, for 6 weeks if delivery by cesarean section. Women should be referred to cardiologist after labor, as postpartum cardiac complications have been confirmed. Finally, they should be encouraged to breastfeed. So if she asked you, can I have a breastfeed? Yes, you can do it. But it is only contraindicated if the patient carry viral infection like HIV, hepatitis C or B positive, okay? But but otherwise, she should be encouraged to do breastfeeding. Significantly lower rates of breastfeeding maintenance when compared to the general population could be explained by the need to restart chelation therapy with oral agents which are contraindicated during breastfeeding, while postpartum chelation using deferoxamine seems to be safe, as DFO is not orally absorbed. Is not orally absorbed. Calcium and vitamin D supplements should be continued also during breastfeeding, but also biphosphonates shouldn't be used during lactation. Only you can start this osteoporosis management by biphosphonate after completing breastfeeding and cessation of breastfeeding. Lastly, all of us should know that pregnancy in thalassemia should be considered a high risk and should always be preceded by complete preconception assessment and the preconception counseling for the patient and the correction of iron overload in the circulation. And the patient with severe myocardial or liver iron overload conception should be delayed. Why? Till you use chelating drugs and improve the condition, then allow for pregnancy. And during pregnancy, close follow-up for maternal and the fetal. Follow-up for maternal because there is risk of complication like cardiomyopathy, liver insult from the load of iron or hemosiderosis, also the risk of diabetes, hypothyroidism, hypoparathyroidism. So maternal follow-up is important. Fetal also monitoring is important during pregnancy for the growth, and because the possibility of fetal growth restriction can occur. So this is the important point. And thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.